Okay, now we are going to start case studies. Welcome to Pharmacology lectures. We'll study case studies related to the topic opioids. Now first, which of the agents listed is a phenanthrene opioid that exhibit a full and immediate response to treatment with naloxone in case of overdose? Naloxone, you will immediately remember it's against morphine. Okay, now see, the correct answer here is morphine. A morphine overdose can be effectively treated with naloxone. Morphine is a phenanthrene. This also you have to remember. Naloxone antagonizes the opioid by replacing it from the receptor, but there are cases in which naloxone is not effective. Meperidine is a phenylpiperidine, not phenanthrene, and the active metabolite normeperidine is not reversible by naloxone either. The effects of buprenorphine and norphine are only partially reversible by naloxone. In most cases, buprenorphine overdose, the dose of the naloxone need to be high and continuous due to higher binding affinity to the mu receptors. So naloxone is effective for fentanyl overdoses. However, fentanyl is a phenylpiperidine, not a phenanthrene. So here the correct option is morphine. Next, a 76-year-old female with renal insufficiency has severe pain secondary to compression fracture in the lumbar spine. She reports that the pain has been uncontrolled with tramadol and it is decided to start treatment with an opioid. Which is the best opioid for this patient? Meperidine, fentanyl, dermal patch, hydrocodone, acetaminophen, morphine. The best choice for this patient is hydrocodone acetaminophen. It is very important to use low dose and monitor closely for proper pain control and adverse effects. Meperidine should not be used for chronic pain, nor should it be used in a patient with renal insufficiency. The transdermal patch is not a good option since her pain is considered acute and she is opioid naive. Morphine is not the best choice due to the active metabolites that can accumulate in renal insufficiency. Now, which statement about buprenorphine is correct? Buprenorphine has a lower number of drug-drug interactions as compared to methadone. You know, buprenorphine is metabolized by CYP3A4 system, so there are concerns about drug interactions. However, compared to methadone, which is metabolized by numerous CYP450 enzymes, the drug interactions concern for buprenorphine is much lower. Buprenorphine has a lower incidence of opioid-induced respiratory depression compared to the mu agonist due to the ceiling effect created by the partial mu agonist activity. Buprenorphine is available in many different formulations, dosage, but these are indicated for either pain management or medication assisted treatment of opioid dependence, not both. And the option D describes the mechanism action of methadone. Buprenorphine is a potent partial mu agonist and a kappa antagonist. Now, a 56-year-old patient has suffered with painful diabetic neuropathy and severe chronic back pain with radiculopathy secondary to spinal stenosis for many years. The patient has failed to receive relief from his neuropathic pain with first-line agents such as TCA, SNRIs, or anticonvulsant. Based on the mechanism of action, which opioid could be considered in this patient to treat both nociceptive and neuropathic pain? Meperidine, oxymorphone, morphine, tapentadol. Tapentadol has a unique mechanism of action in comparison with other choices given here. It has a dual mechanism of action, mu agonist and norepinephrine reuptake inhibitor. So it will treat neuropathic pain, which is associated with diabetic peripheral neuropathy. All other mu agonists will help manage a neuropathic pain, but in some situations, higher doses of opioids are needed to achieve the efficacy. So here the correct option is D. Now, which of the following statements are correct regarding methadone? Methadone is an excellent choice for analgesia in most patients because there are limited drug-drug interactions. No. The equianalgesic potency of methadone is similar to morphine. No. The duration of analgesia for methadone is much shorter than the elimination half-life. Yes. The active metabolites of methadone accumulate in patients with renal dysfunctions. No. Option C is correct here. The duration of analgesia is much shorter than the elimination half-life, which leads to dangerous of accumulation and increased potential for respiratory depression and death. Next, a 57-year-old man who has been treated with oxycodone for chronic non-malignant pain for over 2 years. He now reports increased pain in the afternoon while at work. Which of the following short-acting opioid and is the best choice for the patient's breakthrough pain? Methadone, fentanyl, hydrocodone, nalbuphine. Option C, hydrocodone is correct here because it is commonly used short-acting agent that is commercially available in combination with either acetaminophen or ibuprofen. And methadone should not be routinely used for breakthrough pain due to its unique pharmacokinetics and should be reserved for practitioners who have experience with this agent and understand the variables associated with this drug. Fentanyl is available for treatment breakthrough pain for cancer treatment, and it is not appropriate to use this fentanyl for chronic pain settings. Nalbuphine is a mixed agonist and antagonist, so it could precipitate a withdrawal in patients who are currently taking a full mu agonist such as oxycodone. A 64-year-old man is preparing for a total knee replacement. He is taking medications that are metabolized by CYP450 enzyme system and is worried about drug interactions with the pain medication that will be used following surgery. Which of the following opioids would have the lowest chance of drug interactions in this patient? Methadone, tapentadol, tramadol, and oxycodone. Tapentadol is metabolized via glucuronidation and has not been shown any clinically relevant drug interaction associated with CYP450 enzyme family. All others are metabolized by CYP450. So option B is correct. Now, which of the following statements regarding adverse effects of opioid therapy is correct? The risk of respiratory depression is highest during an initial opioid initiation or following dose increase. Yes, the risk of respiratory depression is the highest when opioid is first initiated or a dose is raised, or sometimes drug-drug interactions will lead to higher opioid levels. Opioid-induced constipation can occur at any time during the therapy and patient does not develop a tolerance to the side effect. Side effects such as nausea and sedation commonly decrease after repeated dosing due to development of tolerance. And chronic opioid exposure has been linked to decreased testosterone levels in male. Case study 9. Now, a 64-year-old man who has been hospitalized following a car accident in which he sustained a broken leg and a broken arm. He has been converted to oral morphine in anticipation of discharge from the hospital. Upon discharge, which medication should he receive from the morphine? Diphenhydramine, methylphenidate, senna, docusate, sodium. Senna is correct. Bowel regimen should be prescribed with the initiation of an opioid since constipation is very common and can occur anytime. And tolerance to this adverse effect does not occur. Senna is a stimulant that is available OTC, and whereas docusate sodium is a stool softener that is ineffective in opioid induced constipation. And combination products that include both docusate and senna are commonly used and can be effective mainly due to the action of senna. Diphenhydramine can be used for urticaria that might occur with the initiation of an opioid, and methylphenidate has been used for opioid induced sedation. A 67-year-old man who has been treated with oxycodone for chronic non-malignant pain with no changes in the dosing regimen for over 2 years. His pain has been fairly well controlled and he remains active, reports satisfaction with his pain regimen and denies any side effects. He has been recently diagnosed with COPD, OSA. Which of the following is the best treatment recommendation for him at this time? Taper off all opioids due to increased risk of opioid-induced respiratory depression. Prescribe naloxone nasal spray to have at home in case he experiences an opioid overdose, prescribe oral naloxone tablets. No action is needed. No, you have to prescribe naloxone nasal spray. Because this patient has just been diagnosed with COPD and OCI, it is clear that his risk is opioid-induced respiratory depression. And pain is controlled, no side effects are reported, so taking off opioid at this time is not the best option. Because of first pass effect, naloxone is not clinically effective for management of an overdose when given orally. Therefore, the nasal spray is the best choice. Offering at home nasal spray along with proper education might be life-saving if an overdose occurs. Providing proper education to the patient and caregivers on importance of having the naloxone nasal spray at home and calling emergency services and is critical in case of an overdose situation. Thank you.